It looks like it could be Gemini, maybe a bit.
Okay, what makes you feel that we're in Gemini?
Just because they're tied together, but then there's also, it looks like there's some drop P wave, so it could be a block as well. And it looks like.
Remember, let's follow that systematic approach, right? Let's go to lead 2. Let's look for our P wave. Let's identify if it's a sinus-based rhythm. If we follow that systematic approach, you're more than likely able to identify the underlying rhythm first. Don't just take this broad spectrum overlook, right? Because we're going to be sucked into so many different avenues. Start off identifying that rhythm, right? Find your P wave, locate your QRSs. Okay, use that systematical approach. All right.
So what about a second degree type 2?
Oh, that sounds much better. How'd you come about that?
I was debating between second degree type 1 and type 2, but it doesn't look like they're getting farther. And then, yeah, the reason why I went with Gemini was just because I was seeing it and then seeing it drop. But yeah, it was just the block that was doing that.
Correct, right? And which is why we need to take that systematical approach, right? So we come up to lead 2. I see this P wave. I've got a QRS, P wave, then I've got nothing. Okay, P wave, or that actually is your T wave. P wave, I've got nothing. Another P wave, QRST, P wave, QRST. We keep moving, and then I've got nothing. So there is every third beat we've got a drop beat. But here's what makes it a second degree type 2. That PR interval, when there is one, remains the same. It's consistent. So within second degree type 2, we're definitely worried about a bradycardic rate. And I'm also worried about ischemia, right? Is this ischemic injury induced? Is this an MI induced dysrhythmia? So being that I've got a 12 lead here, I want to continue on to identify if there's any aberrancies, which I have a narrow QRS, so there's no aberrancies here. I don't see any ectopy, right? I've got no abnormal beats, whether it be a PAC, PJC, or PVCs. And then I start moving through my ischemia injury, right? And I go work through my higher lateral, which looks good. I go through my inferior, which once again looks good. I've got normal T waves in your AVR inverted. Okay. I move into my septal and anterior. Once again, looks good. And then I go into my low lateral, which once again looks good. So I simply have a second degree type 2 AV block here with no signs of an MI. So really quick, what's my rate? Let's see. Maybe 50 beats per minute. So with a rate of 50 beats per minute, we're now going into, are they symptomatic? And if they're symptomatic, are they stable or unstable? And then we can move through our algorithm for symptomatic stable or symptomatic unstable. With a rate of 50, I would expect them to be stable, potentially symptomatic. Remember, symptomatic can mean do they feel weak? Are they tired? Are they short of breath with exertion? Do they get dizzy when they stand up? Right? Are they hypotensive? Do they feel off, right? What generated the 911 call is a potential symptom that can relate to the bradycardia that generated the 911 call. And essentially, we can move through that bradycardia algorithm. But one thing to remember, we can start off with atropine, but when we start to get blocks like a second degree type 2 or a third degree AV block, it's unlikely that this is acetylcholine induced or vagally induced. So it's not likely that the atropine is going to produce much of a change. So we may have to, bypass going up to that 3 milligram max dose and say, hey, I'll give him a milligram as a trial by error type situation. It's not going to be dangerous, right? The risk versus benefit is in heavy in favor of just giving the milligram as you prepare for the next intervention. And then as it doesn't work, we start moving into our beta-1 agonists like our dopamine and our epinephrine.